So hello friends, this is from Chambers and we will be talking about today a new topic, that is the first bacteria of our systemic bacteriology, systemic microbiology, that is Staphylococcus. Okay. So in the previous topic, we had said, let me share the screen. This is a live session. Okay. You all can interact with me and ask me many questions as much as you want. Okay. So yesterday we have talked about, yesterday we said, if I want to differentiate Staphylococcus and Streptococcus, I will be using a catalase test because Staphylococcus is catalase positive. What does it mean? It means that Staphylococcus can liberate oxygen and water because it has an enzyme catalase, and that catalase can break down the hydrogen peroxide, isn't it? And we said if someone is having a catalase enzyme, we say that that bacteria is catalase positive, and vice versa, isn't it? Like that. And then we said further, Staphylococcus have some pathogenic species and some non-pathogenic species. If a Staphylococcus is to be demonstrated that it is pathogenic, for that purpose you have to do another test, that is coagulase test. Coagulase test will tell you which Staphylococcus is pathogenic and which Staphylococcus is non-pathogenic. And we said Staph aureus is a pathogenic Staphylococcus. Why? It has a coagulase. It has a coagulase. It shows us that clumping, isn't it? It shows us that clumping. And then we said in the non-pathogenic, we have two species of Staphylococcus, that is Staphylococcus epidermidis and Staphylococcus saprophyticus. Staphylococcus epidermidis and Staphylococcus saprophyticus, they have to be differentiated. I have two bacteria in my hand and I say how to differentiate them. Then I say do an antibiotic test, that is novobiocin. A novobiocin test will tell me which is which is Staph epidermidis and which is Staph saprophyticus. It has been seen once we do a novobiocin test, yesterday we have learned here. So once we do a novobiocin test, in the novobiocin test, we see there are zones of inhibition. That means this is the novobiocin tablet or a capsule, you can say a disc sort of a thing, and you see it is preventing the growth, the colonies of the bacteria around it. There is clear, say clear. No, this is clear. This part is clear. That means if you see this, it is a sensitive. So who is novobiocin sensitive? Staph epidermidis. If you are getting this type of, appreciating this type of a configuration, then you say it is novobiocin sensitive and it is Staph epidermidis. While as if you are seeing here the in this first one, you see there is no zone of inhibition. You can't appreciate something is getting inhibited, but the colonies are still the same. They are growing as per they are not getting affected. So what do we see is a novobiocin resistance, and saprophyticus shows novobiocin resistance. And I taught you the trick how to remember novobiocin sensitive, novobiocin resistance, novobiocin sensitive. Since you have two bacteria in hand, you have epidermidis and saprophyticus. So so saprophyticus has S, but it is not novobiocin sensitive. It is resistant. It is resistant. And then we said epidermidis. How you have to remember? Novobiocin sensitive. Is it easy or not? So sensitive is not saprophyticus but epidermidis. Opposite you have to remember, isn't it? Now today I want to tell you actually what is the basic. Now we are going into the Staphylococcus. We are officially taking the topic today, that is Staphylococcus. Okay, this is our live session. Okay, so Staphylococcus. Basically, if we go into the Staphylococcus, before this, if I have a gram-positive bacteria, I divide gram-positive cocci. I take cocci right now. I divide gram-positive cocci into two. Remember, first listen to me. One is micrococci, another is streptococci. It's a family, streptococci. Okay. if you want to divide gram-positive cocci, we divide them into two families. Gram-positive cocci. Remember cocci. Just keep listening. I will listen to your questions. In a period of time. Okay. So you have to listen to me. First, listen to me. Your all questions will be answered in this. In this discussion. So micrococci family. This micrococci contains who is in the micrococci family? It is Staphylococcus, and Micrococcus. Micrococcus. Okay, Staphylococcus and Micrococcus. And who is in the Streptococci family? Yesterday, fast. Tell me who comes in the Streptococci family. We learned a mnemonic how to remember the Streptococci family. PES. Very good answer. The football match. PES. PES. PES is Pneumococcus. Pneumococcus. Enterococcus. And S is strapped. Strapped. Yeah. Strapped. Strapped. Strepto. What? Strepto. Which strepto? Which strepto, my dears? We should write directly the streptococcus. Okay. Then the further subclass grouping we will be writing in the individual details. So we said Staphylococcus is catalyst positive or catalyst negative. Yesterday, catalyst positive or catalyst negative. Catalyst positive. Very nice answer. Cat positive. Micrococcus is also cat positive. Micrococcus cat positive. So micrococci becomes cat dash. Micrococci becomes cat dash. This is an interactive session. You can talk with me. You can ask questions. You can fire questions on me. That's okay. Positive. Very nice answer. Micrococci family is a gram positive. Sorry. I'm sorry. Cat positive. Okay. Yeah, gram positive also. Why not? Gram positive but Staphylococcus. Or yes. Okay. So Streptococci. So when I learn, see how I learn. I say like this: Pneumococcus is a Streptococci. Enterococcus is a Streptococci. Streptococcus is a Streptococci, isn't it? Streptococcus itself in that Streptococci, isn't it? This is okay also. So these all should be catalase dash. Streptococci family should be catalase dash. Catalase dash. Catalase dash negative. They're all cat negatives. They're all cat negatives. Okay. Now, what is the difference between them in their morphology? I want to discuss their morphology here. If you see the Staphylococcus, if you gram stain them, if you gram stain Staphylococcus, you will get what? So I will say like this: if you gram stain Staph, you will get they will be in clusters because Staph itself means clusters. You will see it in the form of grapes. Okay. If you see something in a tetrad, what is a tetrad? Tetrad. Micrococcus is a tetrad. I have taught you. Micrococcus is a tetrad on in the gram stain arrangement. Okay. Okay. And if you see the pneumococcus or the streptococcus, pneumococcus was what was the shape of this? Okay, tell me what was the shape of streptococcus? We're applying the principle. What was the shape of streptococcus? Chain. Streptococcus is a chain. Streptococcus is a chain. Pneumococcus is a pair, isn't it? Pneumococcus is a pair. Enterococcus is a pair, isn't it? Isn't it? We remember from the general microbiology principles, isn't it? It is not tough, I hope so. So you are actually taking these classifying. So what is the main motto to explain these things is you are actually taking the gram positive, you are classifying the gram positive cocci on the basis of catalase test. And you are saying accordingly that this is catalase positive, micrococcus, staphylococcus, catalase negative, and streptococcus. And further dividends if you want to differentiate between staphylococcus and micrococcus, then we have to differentiate them, isn't it? We have to differentiate what is the difference between micrococcus and what is the difference between staphylococcus, isn't it? Isn't it? Yes or no? So how to differentiate? Let us write. Let us differentiate. So we are taking now these two from the family. Okay. Okay. Are we all oriented in time, place, person? Are we oriented in time, place, person? Yeah. Yeah, we are oriented. So we are taking first family, that is Micrococcacea, and we are drawing the differences between the two. So since Micrococcacea contains Staphylococcus and Micrococcus, we have to take a difference between the two. What is the actual difference between the two? If I draw a difference between Staphylococcus and Micrococcus, what is the difference between Staphylococcus and Micrococcus? You will always see Micrococcus as a tetrad. You'll see Micrococcus as a tetrad. Micrococcus is a tetrad. Okay, but Staphylococcus will be in which shape? Clusters in the grapes, grapes, grapes. Okay, one difference is this. Second difference, Micrococcus, they will say, I can't live without you. There is a word what people say. I can't live without you. That is, they can't live without oxygen. So they are strict aerobes. Strict aerobes. But Staphylococcus are facultative anaerobes. You have to remember this point. They are facultative anaerobes. Okay. I have taught you the concept of facultative anaerobes. Okay. So if they are strict aerobes, they will be doing oxidation. They will be doing oxidation to the glucose, isn't it? Oxidation. And they will be doing dash if they are anaerobes. That facultative anaerobes, then they will be doing fermentation. Isn't it? Is it easy? Isn't it easy? Yeah, it is easy. Micrococcus is catalase dash. Micrococcus is catalase dash. Positive, very nice answer. Staphylococcus is catalase dash. Positive, very nice. Oxidase positive is who should have, if it has to utilize oxygen. Who is oxidase positive? Micrococcus is oxidase positive. Oxidase, it has oxidase. So oxidase positive is Micrococcus. Oxidase negative is who? Who is oxidase negative? Staph aureus is oxidase negative. Oxidase negative. Okay, easy, easy. Okay. Now we have two chemicals, that is bacitracin. Bacitracin. So bacitracin, if I apply bacitracin to Staphylococcus, it is resistant. Nothing will happen to him. Resistant. Bacitracin resistant. Bacitracin resistant. Okay. Are we able to understand? And who is bacitracin sensitive? Who can be killed by bacitracin? Micrococcus. Micrococcus can be killed by. So if you have any doubts, you can play the YouTube again. Okay. So if you feel that you forgot something or you left something, because this is a live session and you can take the playback, you can reverse you can do anything. It's your video. Okay. So I will be saying in continuity, and you should watch the video for further if you have any doubts. Okay. So resistant and sensitive. Okay. So if I talk about a chemical called lysostaphin, the difference is lysostaphin, it is not resistant, but it is sensitive. It is sensitive to lysostaphin. Who is sensitive? Staphylococcus is sensitive to lysostaphin. But Micrococcus is resistant. Micrococcus is resistant to lysostaphin. Lysostaphin. Okay. Now let us take the first important bacteria, that is Staphylococcus. The first bacteria which we will be learning in our systemic bacteriology. Okay. So first bacteria is, let us start now the discussion about Staphylococcus. Staphylo. Okay. What is the common feature? What is the common feature between a Staphylococcus? What is the common thing? Is no, not common thing. I can say what is the basic characteristic feature. We said we have to discuss something under headings. First morphology. Dividing them on the basis of enzymes also. Then we have to talk about the culture. How can we culture them? Then we have to talk about the pathogenesis and pathophysiology, how they are infecting you. Okay. So Staphylococcus is first point we should write is Staphylococcus is gram positive. Staphylococcus is gram positive. Second thing, what is the shape? You should write everything whatever you know till this moment. Cluster, it has a grapes cluster appearance, arranged in clusters. Okay. Non-motile, non-sporing, non-motile, non-sporing. Non-motile, non-sporing. I hope you know about the spores. Non-motile, non-sporing. Okay. Strictly aerobes or facultatives. Strictly aerobes or facultative. Facultative, very nice. So they are facultative anaerobes. Okay. Okay. Is it okay? So if I take their biochemistry, if I take their biochemical components, what enzymes they have? Biochemical components. What enzymes can they have? They are cat dash oxidase dash fermentation process dash and so cat they are positive, that's okay. Oxidase they are negative, that is also okay. And fermentation, yes. Are we able to understand? Because they we have written facultative anaerobes. Okay. Is there any doubt? No doubt with you. Okay. Second thing to understand is we are classifying them. Then we are saying which staphylococcus is pathogenic and which staphylococcus is non-pathogenic, isn't it? So we are saying we have to describe who is pathogenic or who is coagulase test, isn't it? A coagulase test will tell me whether a staphylococcus is a pathogenic staphylococcus or a non-pathogenic staphylococcus. Coagulase test, who is having pathogenic, who is positive, coagulase positive, Staph aureus, Staphylococcus aureus. And who is coagulase negative? There are two species, Staph epidermidis and Staph saprophyticus. Staph saprophyticus. Okay, and then further on we are dividing them on the basis of Nova and sensitivity. Okay, this is also done. If we see now, first point we have finished their morphology and their biochemical components, what biochemical components they have. Also coagulase will come in that. We should now know how to grow these bacteria. First of all, I want to tell you what is basically the meaning of why they are calling it staphylococcus. You know it already. The staphylococcus is because they are in the form of bunch. Okay, actually there is a Greek word that is staphyle. There is a Greek word called staphyle. Staphyle means bunch of grapes. So that's why they have called it Staphylococcus. Okay, easy. Then we should know how we are able to culture them, which media they grow, and we have known everything about the media, so we will be directly writing about the media. So if you see the media on which they are growing, so the media is the culture media which they are using. The culture media is, if you grow them on a nutrient agar, they will be giving you golden yellow colonies. Golden yellow, that's why aureus. Golden yellow colonies. Golden yellow colonies on the culture media. If you give them a blood agar, so what type of hemolysis dash? We have taught you. So if I give them a red, let us take a red pen, blood agar. If we give them a blood agar, they will be giving us which type of hemolysis? Yes, my dears. Which type of hemolysis? Alpha, beta or gamma? They will be giving us a beta hemolysis. Right? Beta hemolysis. Beta hemolysis means color means the same, or complete hemolysis. I show you the diagram yesterday. I hope you remember. Okay, complete hemolysis, very nice. So there should not be any doubt. So complete hemolysis. Complete means they are, see, the area around this is all hemolyzed. Okay, so this is the beta hemolysis. So complete hemolysis is seen on the blood agar. And you can see some, there are sometimes they say there are pin size colonies. If you see the pin has a head, isn't it? So pin head size colonies is also there. Pin head size colonies is there. Okay. Uh, a question is asked, which is the best selective media? You know the selective media, I hope so. So which is the best selective media? I have some image for you. The best selective media is, what is the best selective media? It is the mannitol. It is the mannitol. Mannitol salt agar. Mannitol salt agar. So mannitol salt agar, please note it. It's important. Mannitol salt agar is the best selective media. Okay, easy. Okay. So do we have any questions? No, sir. No questions. Okay. So why they are giving us golden yellow pigment? They have a color. They have a color. The color is, the pigment is known as Staphyloxanthin. Staphyloxanthins. They are staphyloxanthins, and it is told that if you want to increase the color, you should increase the temperature. So if you do the temperature increase to 22 degrees centigrades, and if you add tween 80, tween 80 is a tween 80 or milk, okay? If you add tween 80 or glycerol monoacetate, they will become more yellow. They will show you more color. Okay, you will be appreciating more yellow, golden yellow color. Okay. So tell me one thing. If I have a McConkey agar now, if I have a McConkey agar, okay, you have learned about the McConkey agar. Can you tell me what is the principle behind McConkey agar? What is the principle? What we have to appreciate in a McConkey agar? So no one is answering. It is actually the lactose fermentation. We are actually seeing whether the colonies are pink in color or not, whether the color change is happening. If the color change is happening, so lactose fermentation is happening. Pink color changes. Okay. So in the, this is we are talking about the mannitol salt agar. So in the McConkey's agar, if there is a lactose fermentation, so who are lactose fermenters? Staph is also a lactose fermenter. Okay. Lactose fermenter is also shown by this Staph aureus. Okay. Staph aureus is also showing. Okay. Easy. Yeah. I hope there is no problem. Okay, so let us choose the color. Yeah, media culture is done. Now let us move to the let us talk about their virulence factors. Okay, let us talk about their virulence factors. So what factors they have to cause virulence? What virulence factors have? Virulence factors of Staph aureus. Okay, let us first classify these factors, what special it is having in its structure. So first is if I talk about is cell wall. If I talk about the cell wall factor, what is present in its cell wall? The Staph aureus. It is peptidoglycan, peptidoglycan, cell wall, peptidoglycan, and this peptidoglycan is thicker. It is thicker like this. It is thicker. Okay, peptidoglycan cell wall is thicker. So if it is thicker, it will be giving rigidity. So this thickness is giving it a rigidity. So it is giving it a rigidity, and also this peptidoglycan will be responsible for inflammation. It will induce inflammation. So induce inflammation. Okay. So what else it is having in the cell wall? We said it has teichoic acid. It has teichoic acid because it's a gram positive. I told you it's a gram positive. So what is the function of teichoic acid? Can someone tell me what is the function of teichoic acid? It gives adherence. It gives adherence. It helps in the adhesion. It helps in the adhesion. For example, if Staph aureus has to attach to, if it has to do an infection of the mucous membrane, so what it will do, it will attach to the mucous membrane surface. So this is, if this is a mucous membrane, so it has a teichoic acid, so it will attach with the mucous membrane. Okay, and it will also prevent opsonization. Opsonization we will be studying in immunology. Okay, So it prevents opsonization. It prevents opsonization. Okay. It has a factor. It has a factor. We are just discussing only about the cell wall. Okay. We are only discussing about the cell wall. Okay. This is A and this is the first. This is the second and this is the third. So what else it has? It has a clumping factor. It has a clumping factor. Clumping factor, or that is known as bound coagulase. Bound coagulase. Okay, it is having a clumping factor, that is the or the bound coagulase. So what is this bound coagulase? There are other people in the Staph family, Staph family, but they are not gram positives. There are some families in the gram negative. For example, we have Staphylococcus lutegenesis, Staphylococcus schleieriferi, isn't it? Staphylococcus coagulans, Staphylococcus intermedium. These are those families which are actually coagulase negative, but in them still there is a difference that they are having free coagulase and some of them have bound coagulase. Okay, I will give you a principle to remember something, that we yesterday taught about two tests, that is slide coagulase test and a tube coagulase test. So what is where are we actually using them? So slide coagulase test, let me tell you a principle first. Slide coagulase test, slide coagulase test is used to detect bound coagulase, bound coagulase, and tube coagulase test is used to check whether the bacteria is having a free coagulase. Okay, so if bacteria is, now it is having a bound coagulase, so which test will you do for the Staph aureus? So which test will you do for the Staph aureus? Slide coagulase test. So we should write, we will do a slide coagulase test. Okay, I will tell you one thing, that Staph aureus is basically both. It is bound coagulase positive also, and not slide coagulase test positive and tube coagulase. So that means it has both free and bound coagulases. Okay, but if some are bound, some are free, then we classify them, we have bound coagulases is Staph lutegenesis, we have Schleieriferi, we have intermedium, that is free coagulase, we have Schleieriferi coagulants. Okay, actually there is Schleieriferi, Staph Schleieriferi, that is bound coagulase. Okay, that's having bound coagulase. But if we have Staph Schleieriferi coagulants, means free coagulase. Okay, I'll be telling you later, just focus here. So clumping factor bound coagulase is a slide coagulase test. Okay, we will do a slide coagulase test, and there we will be appreciating that there will be a slide coagulation reaction, slide coagulase reaction. There will be a slide coagulase reaction. Okay, is it okay? So what else it has in the cell wall is number 4, it's protein A. Protein A is a name of a protein. So what is protein A? A means, I remember from A, is anti-phagocytic. It prevents phagocytosis. It is anti-complementary. Okay, anti-complementary. Okay, with this complement pathway is actually a pathway of inflammation. Okay, you'll be learning it in immunology. I'll be teaching you in the upcoming videos. So other thing is, this protein is chemotactic. Now tell me, if it is chemotactic, will it attract the the chemicals, the mediators of inflammation? So it is chemotactic. So remember, what is the function of protein A? A means antiphagocytic and A means anti-complementary and chemotactic. So it is chemotactic, means it will show chemotaxis. It will augment chemotaxis. You have, if I talk about the antibody structure, antibody we usually make a Y shaped, isn't it? And we have a light and heavy chains above, and we have this crystalline region, isn't it? FC region, Fab and FC region, isn't it? You must have read it in your previous classes. So FC region is the place where you are having, the complement presentation, isn't it? But if, for example, this protein A binds to this region, okay, okay, basically before going into this, I want to tell you there is a reaction that is known as coagglutination. Coagglutination reaction. What is a coagglutination reaction? It means if something binds to FC region, for example, I take this antibody as IgG. If something binds to the FC region, this is the FC region, okay? This is the FC region. So Fab region is this. This is the Fab region, isn't it? This is the Fab region. This is the Fab region. So Fab region is free, okay? So can this Fab region bind to an antigen? If FC is occupied by protein A, can Fab region bind to antigen? Yes, it can bind to antigen. That is the reason once it binds, it will agglutinate. Agglutinate means it will like do some sort of, have you seen the clotting mechanism? Platelet aggregation, bringing things together. So that is the process of coagglutination. So protein A is basically responsible for this coagglutination reaction. Put a star on this. Coagglutination reaction. Okay. It's responsible for coagglutination reaction. Easy? Okay. There is a question. Is there a question? Let me check the chat box. Yeah, there is yes. Okay. So that means everyone is able to understand. Okay. Um, let us talk about the next point, that is there is repeat last point, please. I'm saying if you want to do a coagglutination test, this has two regions. One is an FC region, one is a Fab region. FC region is gets attached by protein A of the, who is having the protein A? Protein A is on the Staph aureus. So once it is attached to the protein A, now other things can bind with the Fab region. This is the Fab region of the antibody. Now you tell me you are binding something like this. Okay, you are having a coagglutination reaction. Okay, easy. Okay, now okay. There is no doubt. Okay. Now see, look at me, please. Please look at me. It should have some toxins also. It should have some toxins also, isn't it? It should have some toxins also. What toxins it has? Let us write like this. So there is a question that someone wrote long back to me. That's what is the reason for this? This coagulase. Actually, what is bound coagulase doing? Let me tell you. What is bound coagulase doing? See, bound coagulase is activating the prothrombin. And if your prothrombin is activated, your fibrinogen will be converted to fibrin. Your fibrinogen will be converted to fibrin, and it is a barrier. It now tell me, you are producing fibrin threads, so will you be preventing yourself, will you be able to make antiphagocytic, isn't it? You are now putting a barrier. You are putting a barrier, isn't it? Aren't you putting a barrier? I am a bacteria and I am producing fibers around me. So I am actually making fibrin. So I am making antiphagocytic. So I also say bound coagulase is antiphagocytic. So Staph aureus is so clever that it makes fibrin around itself, and it prevents phagocytosis. That is, it's an antiphagocytic sort of a barrier, isn't it? And you detect it by slight coagulation test. But I want to tell you one thing is every Staph aureus will not show. Okay, at least there will be some percentage which will not be showing this bound coagulase test. So remember that. Okay. And by the way, I want to add another point for this coagglutination reaction is, if you want to see this coagglutination reaction, you should use the special strain of Staph aureus. The strain is known as Covan 1. Covan 1. It's Covan 1 actually. So if you want to check the strain, you should use the Covan 1 strain. That is, and Staph aureus, you have to choose the Covan 1 of the Staph aureus. Why? Because it is rich in protein A. So if you have more protein A, then you will be, it would be easy for you to appreciate the coagglutinating reaction. Coagglutinating reaction. Are we able to understand? So yeah, yeah, okay, okay. Is it okay? So now we proceed to the toxins. What toxins it has? Let us write about the toxins the bacteria is having. The toxins which the Staph aureus. Let us put it in the. Um, let us put it like this. The toxins. What toxins is the bacteria having? Yeah. So the toxins this bacteria has is, first is a membrane active toxin. First is a membrane active toxin. And the membrane active toxin of Staph aureus, let us take the first membrane active toxin, that is hemolysin. It has hemolysins. Hemolysins. It has hemolysins. Okay. So what hemolysins it has? It has alpha hemolysin. It has beta hemolysin. It has yeah. So we have alpha hemolysins, a beta hemolysins, and a gamma hemolysin. Okay, delta hemolysin. Sorry. So we have to remember their properties. What are these hemolysins actually doing? So how I remember them is I will put a like this: alpha, beta, and gamma. Okay, alpha hemolysins, beta hemolysins, and gamma hemolysins. Okay, gamma hemolysins. Let us classify them. The three. So this alpha is LDL. LDL. I remember it by LDL. Okay, LDL means low density lipoprotein, isn't it? Isn't it? Yes, first year people. Yes or no? So what is LDL? It's not here LDL basically. Okay, it's not LDL actually. It is L for lethal, alpha lethal, D for dermonecrotic. What is dermonecrotic? Necrosis of your derma. Okay, your skin. So dermonecrotic. It is dermonecrotic. And L for leukocidal. What is leukocidal? It will kill the leukocytes. Leukocidal. It kills the leukocytes. We have been seen it. Okay. Okay. Alpha hemolysis is showing us it shows us a very beautiful property. What is the beautiful property about alpha hemolysis? Is it is showing us a paradox. Let me write like this: paradoxical reactivation. What is the process of paradoxical reactivation? The process, this actually means, if we heat this toxin, if I heat alpha hemolysin, if I heat it, this alpha hemolysin gets inactivated. It gets inactivated at 60 degrees. It gets inactivated at 60 degrees. And if I have to reactivate it, then what should be the temperature? Can someone tell me? What should be the temperature? Yeah, someone can tell me what is the reactivation temperature? Reactivation temperature is 100 degrees. Okay, reactivation temperature is 100 degrees. So it gets reactivated at 100-degree temperature. Okay. So sometimes some books will be writing 80 to 100, so you can also write that. So don't keep it like you have to remain, some books may be writing this. So at 100 degrees or 80 to 100 degrees, you will see so paroxydical reactivation, is it a temperature dependent or temperature independent? Paradoxical reactivation, is it temperature dependent or temperature independent? So actually temperature is able to define it. So we can call it that it's a temperature dependent, and we are able to demonstrate it on the basis of temperature. So if you have a temperature of 100 degrees, you will have a reactivation of alpha hemolysin. If you have a temperature of 60 degrees, it will get inactivated. So that is the special thing you have to remember about this. So two features about alpha these features. Lethal means it can kill, leucocidal, thermonecrotic, paradoxical reactivation. Beta hemolysin. Beta hemolysin has a special enzyme. It is a special enzyme, that is sphingomyelinase. Sphingomyelinase enzyme. You have sphingomyelin, it's a phospholipid, okay, covering your cells, so it can destroy that. Okay, this beta hemolysin shows me another phenomenon. What was the phenomenon associated with alpha hemolysin? Can we remember what was the phenomenon associated with alpha hemolysin? Paradoxical reactivation phenomenon. Now beta hemolysin has a phenomenon that is hot cold phenomenon. It has hot cold phenomenon. Hot cold phenomenon. Okay, what is hot cold phenomenon? I will tell you what is hot cold phenomenon. If you want to see the hemolysis of RBC, okay, if you give a sheep RBC, I put sheep RBCs in a medium, sheep RBCs. This is sheep RBCs, and in the sheep RBCs, I am putting this beta hemolysin. So what is happening is that at your body temperature, that is 37 degrees centigrades, the hemolysis will start. The hemolysis of RBC will start. RBC damage will start, and it will complete by 4 degrees. 4-degree temperature, it gets completed. So at 4 degrees centigrades, the hemolysis is completed. Easy. Okay. So can I say in Staph aureus, the hemolysis is best or better seen at 4 degrees centigrades? Can I say in Staph aureus, the hot and cold phenomenon, the beta hemolysis is best seen at 4 degrees centigrades? So I can write that. So you can write that. You can better appreciate this at 4 degrees centigrades. So if someone tells you, please look at me, please answer me in the chat box. If someone asks you, is Staph aureus beta hemolytic, gamma hemolytic, or alpha hemolytic? Beta hemolytic. Best appreciated at dash degree centigrades. Best appreciated at dash degree. Beautiful answer. 4 degrees you can appreciate better for Staph aureus. You can. Okay. So leukocidin. So let me talk about leukocidin. It's some books write it at a different toxin, but let us make it easy. So let us first write about this gamma hemolysin. Okay, in the gamma hemolysin. But by the way, I remember a toxin. I remember a toxin from Clostridium perfringens. There is a bacteria that is Clostridium perfringens. Let us write that point here. I have a bacteria that is Clostridium perfringens. Please write a box. Clostridium perfringens. This Clostridium perfringens has a toxin. The toxin is known as alpha toxin. It has a toxin that is alpha toxin. What is this alpha toxin specially doing is it is able to show the same hot cold phenomenon. It's alpha toxin. So the examiner may be confusing you. It will give you the alpha toxin of Clostridium perfringens shows hemolysis of RBCs at dash temperature. You may get confused. Oh my god, alpha hemolysin was 80 to 164 cannot be the answer. No, it's wrong. You have to remember the alpha toxin of C. perfringens shows the same phenomenon like the beta hemolysin of the Staph aureus. Are we able to understand? So Clostridium perfringens, the alpha toxin of the Clostridium perfringens shows the same phenomenon like the beta hemolysin of Staph aureus. Third thing to understand about this gamma hemolysin, third thing we should mention is gamma hemolysin is basically a dual toxin. It has 12 components. So dual toxin or a bicomponent toxin. What is this bicomponent toxin is? It has two properties. Means it will be having two properties if it is made up of two components. The two components is membrane. No, it has a property. It has a property to damage the membrane. So let us write like this. Membrane destruction property. It has a membrane destruction property. Okay. So sometimes this component may be present, the both components may be present or cannot be present. So if both the components are present, if gamma both components are present, we call it dash. Very nice name for that. It has a very nice name. Can I write the name? Should I write the name, ideas? So the name is synergio hymenotrophic toxin. Okay, so synergio hymenotrophic toxin. Okay, are we able to understand? Now let me write the definition for you. What is a synergio hymenotrophic toxin? First, you should write it is a bicomponent toxin like this. It is a bicomponent toxin. Second thing to write about this is like which examples gamma and PV toxin. Okay, you know, if you have a gamma and PV toxin, what is PV? Pontovalentine toxin. I will be telling penton valentine leukocidin. Okay, it has another toxin which we'll be reading, that is penton valentine leukocidin. Okay, so this is gamma. So gamma is a component of this. It's a bicomponent, isn't it? So gamma and PV, if they are present, both of these toxins are present in this bacteria. So we say this bacteria is having synergiohymenotropic toxin. What is synergiohymenotropic toxin? If there are bicomponent toxins such as gamma and PV, if there are two toxins, that is gamma and PV, and they are acting synergistically. What is synergism? Means both are acting, giving a high additive effect, high additive toxin property. They are synergistic. So this synergism will, we call them as synergiohymenotropic toxin. I'll be able to understand. So gamma and PV are synergistically acting, synergistic together. So this is synergiohymenotropic toxin. Let us talk about this PV. Okay, let me discuss this PV here only. So what is PV? PV is penton Valentine's Day toxin, isn't it? Some people are Valentine's Day people. So Valentine leukocidin. Okay. What is first thing to write about this pentovalentine toxin? It is a synergiohymenotropic toxin. Same point for this, synergiohymenotropic toxin. Third thing to remember, it is dermonecrotic. Can you tell me which toxin was dermonecrotic? Which other toxin? Which toxin of Staph aureus was dermonecrotic? Alpha toxin. This dermonecrotic and leucocidal, because it is saying leucocidin, so we should write leucocidal. Okay, there is no problem. Okay, there will be a question for you. The question will be, they will be putting three options in your exam, and they will be telling you which of the following, beta, gamma and delta, which of the following is able to lyse human RBCs, which of the following is not able to lyse human RBCs or rabbit RBCs. Directly put the answer beta hemolysin. Beta hemolysin does not lyse human or rabbit RBCs, but gamma hemolysin does, because it has a bicomponent protein. Delta. What is delta? What can I remember from delta? Delta means detergent. It has a detergent like action. Okay. So detergent like okay. Okay. So why they are called penton valentine toxin? Because they have they can damage the polymorphonuclear lymphocytes and macrophages. Okay. And there will be a question that there is a community acquired methicillin resistance Staph aureus. We'll be reading the resistance of them later. So I'll be telling at that time only. Okay. So yeah, let us come back. So Penton, Valentine, leukocidin, synergohaminotropic toxin. We have read this. Now let us talk about this next toxin. The toxin has which toxin we have to write. So hemolysin. Now let us come to next toxin, that is epidermolytic toxin. Epidermolytic toxin. So since it is epidermo means epidermis, lytic means breaking. So it will break the epidermis. Or can I say it is exfoliation? Do you have exfoliating creams at your home? Some girls must be knowing that exfoliating creams, exfoliation. So this is an exfoliatin. It is an exfoliatin. Exfoliatin. So this is an exfoliatin. Okay, this exfoliatin which the Staph aureus is having, it is basically two exfoliating. One is, it has two types of antigenic types of exfoliating, that is EFA and EFB. EFA, EFB. What is the difference between the two? EFA is a chromosomal mediated. It is a chromosomal mediated exfoliatin. It is a chromosomal mediated exfoliatin, while as EFB is a plasmid. It is a plasmid mediated. We have read in our this. Okay, you have cell junctions. Have you read about cell junctions? Have we read about cell junctions? We have read about the cell junctions. We had desmosomes. Do you remember the desmosomes, belt shaped desmosomes? So desmosomes were putting the cells together. Now if I have this epidermolytic exfoliatin, can it damage these? It is lysing these cell junctions. It is damaging these cell junctions. It is damaging these cell junctions. This is known as epidermolysis. So will the cells, will there be epidermolysis? Will there be cleavage of desmosomes? Okay. Can it lead to peeling of skin, scaldings? So this process is known as. So this process will be known as. Now let me show you the pathology, how it will destroy. If this is an exfoliating, what is this exfoliating does? This, the desmosome is made up of a protein. The protein is known as desmoglein. Desmoglein 1. Remember this. It is made up of a protein known as desmoglein 1. What happens in the desmoglein is this desmoglein is attacked. This is lysed. This is proteolysed. Proteolysis happens by which toxin? Which epidermolytic toxin. So this epidermolytic toxin, exfoliative toxin, this epidermolytic toxin will attack this. It will kill this. Once it attacks the desmoglein, and we know we have many layers of skin. One of the layer is a stratum granulosum. Okay, so stratum granulosum is the basic site of action of this toxin. Okay, by the way, I want to tell you the receptors. These receptors. Toxin has to bind to a receptor, isn't it? A toxin has to bind to its receptor. So while binding to the receptor, there should be presence of receptors is important. So which people are having the receptors for this? Neonates, a 28-day newborn, a 28-day newborn is a neonate definition. Neonate or young adults, they are having the receptors. Okay, but adults only those who have skin diseases. Okay, now tell me, if you are attacking, these are two cells, you have two cells or three cells. Let us make like these cells. Now you are having a belt-shaped desmosomes. These belt, they are actually giving the adhesion. They are keeping them together, binding them together. Can I say there will be splitting when they are destroyed? There will be splitting of these cells. So we call them mid-epidermal split. We call them mid-epidermal split. This I am connecting with dermatology. Okay, I am going into detail. Okay, so when mid-epidermal split happens, that leads to generalized exfoliation. That leads to generalized exfoliation. You will be seeing the skin getting removed. Okay, And this disease, this condition, all this pathogenesis, all this what happened till now, this final generalized exfoliation, this process happens in a disease known as Ritter's disease or Writer's disease. This Ritter's disease Ritter's disease is also known as scalded, the same feature shared by this scalded skin syndrome, SSS, scalded skin syndrome. Are we able to understand? This causes scalded skin syndrome. How will you diagnose this case? How to diagnose this? Directly go for how to diagnose. Diagnosis is written like this for the first year people. We have ELISA. We go for ELISA test. Okay. ELISA test. You take a serum and do the ELISA and check whether EFA or EFB is present. Okay. Whether EFA or EFB is present. You have to check this only because we said EFA or EFB. Only two can be present, isn't it? So after that, how will you treat the patient? How to treat? You will give topical coverage. You will give topical coverage, topical care, topical care, and you will start IV parental antibiotics. Parental means IV. Okay, parental antibiotics. Which antibiotics? Staph sensitive. Staph sensitive. The antibiotics to which Staphylococcus is sensitive to. Easy, so easy, isn't it? See, we are actually destroying the toxins, sending the antibiotics by the blood circulation. And on the above, you are seeing some scaling happening. So you will apply some cream, isn't it? See, it's easy. Okay, easy. I hope you are enjoying. Okay, so where is the logo? Logo is not coming yet. What happened? Uh, Logo is not coming. Why? Yeah, now it will come. Okay, so you have seen this epidermolytic toxin. Can we see some enterotoxins which it has? Enterotoxins. Okay, okay. So one thing I want to learn, I want to teach you, if this scalded skin syndrome is happening in neonate, we call it Ritter's disease. If this happens in neonate, we call it Ritter's disease. But if it happens in adults, we call TEN. If this generalized exfoliation happens in an adult, we say TEN. TEN means toxic epidermal necrolysis. So TEN happens in adults, we call it adults. In neonates, we say Ritter's disease. Okay. Second question will be asked. Oh, I don't want to go in that. There is a pemphigus neonatorum. That is a milder version of this toxin. Okay. Let us go to the enterotoxin. Okay. Let us go to the enterotoxin. So what enterotoxin is present in the Staph aureus? So Staph aureus has which enterotoxin? By the way, at least it secretes 15 antigenic types. Okay. At least 15 types of enterotoxins. Okay, and the nature of these toxins are and the nature of these toxins is they are highly heat stable. Okay, they're highly heat stable. Okay, this enterotoxin is actually responsible for your food poisoning. Food poisoning. This enterotoxin causes food poisoning. So in food poisoning, they are what is happening is, you have your vomiting center in the medulla. Your vomiting center is in the medulla, isn't it? And you have uh, you know you have 12 pairs of cranial nerves, isn't it? So what is happening, what is this toxin doing is your vomiting center in the brain, sorry, your vomiting center in the brain, it gets stimulated by this toxin. This toxin stimulates your vomiting center, and also this toxin will lead to vagus nerve stimulation. Vagus nerve is stimulated. This vagus nerve is also stimulated. Okay, that is how this toxin is doing the food poisoning. Okay, so how many what is the incubation period for this? incubation period, the time taken for the toxin to produce the desired effect, from the point of infection to the that definition. So food poisoning, the incubation period is less than 6 hours. The incubation period is less than 6 hours. Okay. Okay. Now, for example, you went to a a supermarket, and you bought a cooked food, or you bought some milk products, or you bought some already made salad, something. So if it gets contaminated by this toxin, so these toxins are preformed, isn't it? The toxins will be preformed, and they will enter your circulation, your body, sorry. Okay. So your IP is less than 6 hours. And what will be the clinical features of the patient? The clinical feature of the patient will be, once he comes with the enterotoxin poisoning, this poisoning of this Staph aureus, he will present with nausea. He will present with vomiting, and he will have watery diarrhea. So these are the clinical features of the patient. But it has been seen that these all clinical features will resolve at around 10 to 12 hours. So a natural spontaneous resolution is seen at around 10 to 12 hours. Okay. So how to diagnose? How will you diagnose that someone has an enterotoxin, this food poisoning? Directly do the ELISA. ELISA, take stool as a sample, or take vomitus, isn't it? Vomitus, isn't it? Or you take that food which he was eating as a sample, and check whether the person is actually having the poisoning of this or not. Okay. So we don't actually give antibiotics for this. Okay, we don't give antibiotics for this. How to treat this poisoning? Only give symptomatic treatment. Only check according to symptoms. Okay, treat the patients according to symptoms. Okay, are we able to understand? So it's not, the purpose right now is not to teach you medicine, but we are actually learning microbiology. So you can't. We have to go. No, we have to learn medicine for this, to understand how to manage a patient and everything. Right now we are telling you a simple things. Relating some simple clinical things with this. Okay. Otherwise, right now, on the basis of microbiology, you can't go for a treating someone, and you have to study part of medicine also, and pharmacology also. So it will, later on you will be able to treat this patient. But right now, remember that what are the symptoms and all that. Okay. One syndrome is seen in Staph aureus infection. It has a toxin, that is toxic shock syndrome toxin 1. It has another toxin. The toxin is known as toxin. Let us write it like this. So it has a symptom, that is toxic shock syndrome toxin. Toxin Toxic shock syndrome toxin 1, that is known as TSST1. Okay, TSST1. It was actually called, its old name was, he was called by the parents as enterotoxin F. Enterotoxin F was called by the parents as enterotoxin F. So formally it was called. Uh, by the way, someone is wanting me to tell what is this Vegas doing. This Vegas is actually doing what? It is increasing your peristalsis. It moves, it increases the gut motility, your colonic motility. So once motility is there, you will have diarrhea. You are stimulating the motility. How you will understand? So intestinal paralysis, not paralysis, intestinal peristalsis. So your intestinal peristalsis is getting stimulated. Okay. By the Vegas now. Vegas is everywhere. Okay. So this TSST toxin, that is the enterotoxin F, it is actually, you know, we can say it is a pyrogenic toxin also. Okay. It is a pyrogenic. So pyrogenic means fever causing toxin. Okay. Pyrogenic toxin. It is a super antigen also. Super antigen. Okay. It is super antigen also. Yeah. Any questions? No, we don't have. So you know what happened? Who what in which people this toxic shock syndrome happened? You know, the females, I'll be teaching you, wait a second. The females which are having, which use vaginal tampons. Okay, you may remember, you may understand this. Vaginal tampons. Okay, like the menstruating females, they use, you know, actually I'm talking about the risk factor, what can cause this syndrome. Okay, so the risk factor is menstruating females using vaginal tampons. Okay, vaginal tampons. So uh, they have this syndrome, can see this syndrome. So what is, so can I say TSST1 causes TSS, toxic shock syndrome, toxin causes toxic shock syndrome. Okay, TSST causes TSS, toxic shock syndrome. Toxin 1 will cause toxic shock syndrome. A toxin is causing a disease, isn't it? A toxin is causing a disease. Okay, you know, some books may be classifying this on the basis of, you know, some classify this TSS, you know, they classify it menstrual TSS and non-menstrual TSS. Let me write that also, some people may have confusion. So you know, this toxic shock syndrome, they say, is of two types. One is menstrual TSS and non-menstrual TSS. Non-menstrual, so menstrual will be for females, isn't it, because they're menstruating. Okay, so if the vaginal tampons have that toxin, you know, increased toxin production by the colonized Staph aureus, we say menstrual TSS. Okay. And mostly if you see what is the toxin, which type of toxin is causing the menstrual TSS, you know, in that vaginal tampon, it is TSST1. So remember that TSST1 is the most common, approximately 100%, I think. The mostly you will be having the outcome that the patient has been affected by TSST1. Non-menstrual TSS means, you may remember, you can understand. Non-menstrual TSS means caused by some other enterotoxin. This was which enterotoxin? This was enterotoxin F. This will be caused by enterotoxin B, enterotoxin B or enterotoxin C. Okay, easy. There should not be any doubt. Okay, so what are the symptoms? How you will be understanding that the person is having a TSS? There should be some symptoms. So let us write some clinical features. What are the clinical features of the patient? The patient will present with rash. He will have rash. He will have fever. He will have hypotension. The blood pressure will decrease. Hypotension. The blood pressure will decrease, and there will be MODY will multiple organ dysfunction. He will have multi-organ failure. He will have multi-organ failure. A multi-organ failure. Okay. How will you diagnose? There is a test known as latex agglutination test. How to diagnose this? There will be a latex agglutination test. Latex agglutination test, or you can use an enzyme immunoassay. Enzyme immunoassay. Okay, what you will be checking by this test? You want to see the toxin TSST. Okay, now if you want to check the genes, if you want to check the genes of TSST, the genes, there is a gene 1 and gene 2, so you can detect it by PCR. You remember PCR. Okay, are we able to understand? Okay, what will be the treatment for the toxic shock syndrome? We actually give clindamycin. Clindamycin. And clindamycin is, what is this doing? It reduces the toxin synthesis. The toxin synthesis will decrease. Okay, so clindamycin reduces the toxin synthesis. It reduces the toxin synthesis. Okay, but if you see it is resistant, so now tell me, if you see the patient is having MRSA, what drug will you do? If it is having a community acquired methicillin resistant Staph aureus, infection, which drug will you give? So we said if there was a Staph aureus infection, we used to give methicillin. We used to give methicillin, and if methicillin it became resistant to methicillin, that is it became MRSA, we used to give vancomycin. We used to give vancomycin. Okay, and if also vancomycin resistance was there, we used to give that Gramins. So decreased toxin synthesis, you give clindamycin, and if you see that it is a strain of MRSA, if you found that it was a strain of MRSA, you will give vancomycin. You will give vancomycin. Okay. So basically there was a criteria. I want to discuss this criteria here. For having the clinical features, CDC, CDC gave a CDC gave a criteria. CDC is Center of Disease Control. Center of Disease Control Center of Disease Control, they said there should be some criteria to diagnose. So if you want me, I can tell you here only. Okay, let me integrate it here. So they said there should be a criteria to say whether patient is having TSS or not. So what the criteria was, they said if the fever was greater than 102 degree Fahrenheit. If the fever was greater than 102 degree Fahrenheit. Second criteria, if BP was less, that is systolic blood pressure, the systolic blood pressure was less than 90 mmHg. The systolic blood pressure is less than 90 mmHg. And if you see a rash, and rash they describe perfectly as maculopapular rash. Maculopapular rash. Maculopapular rash. Okay. And in the multi-organ failure, which organs they took, they said if there is three or more organ involvement, if there is three or more organ involvement in the multi-organ dysfunction, are we able to understand? So if there is three or more organ involvement, so which organs? So if I take the gastrointestinal tract, if they present with nausea and vomiting, if I talk about the CNS, if they present with mental confusion, if they present with mental confusion, or if their platelet count becomes less than 1 lakh per mm cube, or if I check their enzymes in the blood, liver enzymes, their liver enzymes will be increased. So liver enzymes, you should know, is SGOT and SGPT. SGOT and SGPT. Because see, if this is a cell, this is a liver cell, okay? This is a liver cell, and cell contains enzymes. So liver cell contains SGOT and SGPT. If you damage the membrane, SGOT and SGPT will come out in the blood circulation, and you will be able to measure them. So there will be an increased amount of, they will increase two times, at least two times, two times more than their original value. Okay. Now, if there is a kidney failure, kidney will not be able to throw, the creatinine out, isn't it? Kidney won't be able to throw the creatinine out. So creatinine will increase. If kidney is failing, then creatinine will not come out. Creatinine will not come out. So they will have a increased creatinine. They will have a increased creatinine. So creatinine will increase. How much? Two times. Two times of the original value. Okay. How able to understand? If their muscle is getting damaged, then you will have increased concentration of creatinine phosphokinase, isn't it? Muscle has an enzyme, creatinine phosphokinase, that will increase to two times of their original value. How able to understand? So this is the criteria they said. Okay. So if from these three or more organs are having these symptoms, if you see three or more symptoms like this, you can diagnose it as TSS with other features of fever. They gave us this CDC. They gave us another criteria which I forgot to tell you, forgot to mention here, is this. There should be, if you are taking the sample, for example, a blood sample. If you are taking a blood sample from this patient TSS, or you are taking a throat swab, a sample, or you are taking a CSF, cerebrospinal fluid, and if you culture them, he said, the CDC have told us that the culture should come negative. The culture for gram for other bacteria should be negative. For other bacteria should be negative. Means For example, Rickettsia. There should not be presence of any rickettsial infection. There should not be any presence of leptospira. There should not be any presence of measles. Okay, so rickettsia, leptospira, and measles. There should be a negative serology. You should not be having some antibodies or components against these three infections in the body of the patient. Then only you can say that there is a TSS. So how many things we mentioned? We mentioned one, fever; second, BP; third, rash; fourth, three or more components from this, that is liver, kidney, muscle, platelet, CNS, and last is negative result for all these from the three sites, that is the blood, throat, CSF. Then only you can diagnose the person as TSS. Okay, and we said the menstrual TSS is for happening due to the tampons, and mostly the colonized bacteria is Staph aureus, and the toxin is TSST1. But the non-menstrual case, you have a Staph and enterotoxin B, which is actually causing the non-menstrual TSS. Okay, although don't remember, don't one thing to mention here is people take only that TSS is happening in the females only. No, TSS can happen equally in the males also. Okay, so TSS infection can happen in the male also. Okay, okay. So I'm not saying equally. I can't use the word equally, but I'm saying rarely, but will affect. Rarely, but will affect. Okay. So what if there is a TSST1 toxin? If there is TSST1 toxin, then the name of the antibody in the body should become anti-TSS1 TSST1 antibody, isn't it? If I am making antibodies for a specific thing, my name becomes anti-TSST1 antibody. If toxin is TSST1 toxin, then antibody in my blood should become against to this toxin, that is anti-TSST1 antibody. For example, if I have an infection of, for example, I take an example. I have an infection of, for example, any spirochetal infection. So spirochete, if I have an infection of spirochete, and if I say I have an antibody for spirochete in my body, the antibody, antibody is a defense which is actually preventing the infection, which is actually becoming, trying to become against this infection. I will say it is anti-spirochetal antibody. Can I use the word anti-spirochetal antibody? If I have a spirochetal infection, then I will say anti-spirochetal antibody. My body will make antibodies. My body will make antibodies to prevent the infection, isn't it? So if I have a TSST1 infection, I will say I will have anti-TSST1 antibody. Anti-TSST1 antibody. Are we able to understand? So I hope you are clear with the today's concept. We will be tomorrow taking another half session where we will be discussing it in more detail in the part 2 of this video. So this is actually the Staphylococcus aureus part 1, and next video we will be talking about the Staphylococcus 2 infection. So I want to have a review of whatever we learned, and we will have an interactive 5-minute session to end this session. Okay, so I want to ask some things and you have to text me, okay, so that we have a rapid review of everything, because we don't want to make a separate video and give you that rapid review in that. So I hope here only you can learn, study. You have studied, now you leave my class, just you should learn something. Okay, so let us begin like this. What is bound coagulase actually doing? Okay, I will do a true or false. Okay, I will say a statement and you have to say true or false. Okay, so bound coagulase actually makes more fibrin. True or false? Bound coagulase makes more fibrin. Very true, very nice. And it is antiphagocytic. It is antiphagocytic. That's a beautiful answer. So alpha hemolysin shows synergohymenotrophic phenomenon. It is a synergohymenotrophic toxin, sorry. It's a false. It shows hot and cold phenomenon. It shows hot and cold phenomenon. False, very nice answer. It's a false answer. Alpha hemolysin shows paradoxical reactivation. So I will tell a definition and you have to say true or false. Paradoxical reactivation means it is inactivated at 100 degree and reactivated at 60 degree. False answer. It is actually inactivated at 60 degrees and it is reactivated at 80 to 100 degrees. Very nice answer. So LDL is about alpha hemolysin. LDL mnemonic is about alpha hemolysin. Very nice answer. True. So by LDL mnemonic we mean lethal dermonecrotic leukocidal. Very nice answer. So sphingomyelinase enzyme is beta hemolysin. That's also a true answer. Beta hemolysin shows hot and cold phenomenon. Your copy should be closed. We wanted a mind game to remember in the brain. Very nice answer. So hot and cold phenomenon means hemolysis is completed at 37 degrees. False answer. Actually, it is completed at 4 degrees centigrade. So beta hemolytic bacteria shows no hemolysis. Beta hemolytic bacteria shows no hemolysis. That's a false answer. Actually, beta hemolysis is actually a complete hemolysis with a yellow region. Okay. Uh, in, in that synergy of hemanotrophic toxin is a basically a bicomponent toxin. Very true answer. Penton valentine leukocidin is basically a synergy of hemanotrophic toxin. Beautiful answer. Beautiful answer. So I will tell you a one. Now we have to write one word for everything. Okay. So epidermolytic toxin is also known as dash. Epidermolytic toxin is also known as dash exfoliatin. It is of two antigenic types. Can we write the two antigenic types of epidermolytic toxin? EFA, EFB, very nice answer. It proteolyses the dash protein on the desmosome. It proteolyses the dash protein in the desmoglein. Beautiful answer. Desmoglein is present in dash. Desmoglein is present in dash. Desmoglein is present in dash desmosomes. That's a beautiful answer. So generalized exfoliation in neonate is called dash. Generalized exfoliation in neonate is called dash. Ritter's disease. Beautiful answer. Generalized exfoliation happening in the adults. Toxic epidermal necrolysis. That's a beautiful answer. How to diagnose exfoliating? How to diagnose epidermolytic toxin? How to diagnose Ritter's disease? ELISA, that's a beautiful answer. Which fact, what will you be looking in the ELISA? What to search in the ELISA of the patient? Beautiful answer. EFA, EFB, treatment, how will you treat an epidermolytic exfoliating infection, Ritter's disease or 10? How to treat? How to treat? Yes, answers from everyone. Yeah, it's topical coverage. We will be giving a parenterals also and anti-cephalocal antibiotics. That's a very nice answer. So, enterotoxins, can you tell me what is the incubation period for an enterotoxin? Beautiful answer. Can you tell me the clinical features of enterotoxin? The clinical features of enterotoxin. Beautiful. Nausea, vomiting, and watery diarrhea. So, what you will be? How will be diagnosing enterotoxin? What components will be using as a sample? What components as a sample? But all should answer me. All should answer me. All should contribute in this class. So there is stool, there is vomit test, there is food. Very nice answer. Will you give antibiotics for enterotoxin? No antibiotics. It's just a symptomatic treatment which you will be giving. Very nice answer. So can you tell me who causes toxic shock syndrome? Who causes toxic shock syndrome? That's a beautiful answer. TSST1. Can you tell me who is the most common cause of non-menstrual type of TSS? Non-menstrual type of TSS. Most common cause of TS non-menstrual type. Beautiful answer. Enterotoxin B and enterotoxin C. That's a beautiful answer. So can you please tell me? What is the mechanism by which enterotoxin work? What do they do in your body? What are they actually doing? What are they stimulating? they increase your peristalsis. So they are actually stimulating your vagus nerve, and also your they are actually increasing your this vomiting center also. Okay, your vomiting center and your this gets stimulated. So is it heat stable or heat labile? Is enterotoxin heat stable or heat labile? It is heat stable. Okay, very nice answer. Last question I will ask: how to treat a toxic shock syndrome infection? Okay, tell me first the diagnosis. How will you diagnose? How to diagnose? What you will be using for diagnostic purposes? No, diagnosis, latex agglutination test. What to check in the latest agglutination test? What will you search for? What will you search for? Beautiful answer, TSST. So how to treat a toxic shock syndrome? Clindamycin. So if patient is having MRSA resistant, he is an MRSA resistant. MRSA, yeah, vancomycin. You people are great. It was awesome. Thank you very much for your time. And we will see you in the next video. And we will be continuing the next topic in the next. If you have not subscribed to my YouTube channel, so you can subscribe and listen to the more videos like this. And thank you. Have a nice day. Bye bye.